So, welcome to this episode of a mini series of bite-sized consultations with my wonderful colleague, Dr. Shilpa McQuillan. Hello, Shilpa. How are you?
Hi, Amantha. I'm good, thank you. How are you?
I'm fine, thank you. I'm fine, thank you. Now, Shilpa and I struck upon this idea on the back of some conversations we've been having. And we did a podcast together for my other series, Menopause Conversations. And one of the things that I think Shilpa is absolutely brilliant at is taking what can seem complex, and she puts it into such simple words and sentences that means that it's so memorable. She's an incredibly engaging speaker. She's so insightful and knowledgeable. And you get two for the price of one with Shilpa because she's a gynaecologist and a menopause specialist. So, I mean, that is such a powerhouse of a combination. So what we thought was, didn't we, Shilpa? We thought we could do a series of talks together. So you're not just going to get 1, 2, 3, 4, you're going to get 6 with Shilpa and I. And we thought this first one, we're going to treat it almost like the advice that we give people. And what we advise people is, if you're going to start talking about menopause or your health, your intimate health, we recommend you should really be booking a double appointment. And Shilpa tells me on average that is about 20 minutes. So in the next 19 minutes, because you've had a minute already, we're going to talk to you about some myths. We thought this could be a really nice opportunity to bust some myths. We've got some great other topics coming up. We'll tell you about what the second one is going to be. But these are going to be just sort of bite-sized. So you can grab yourself a drink and you're going to just get all this wonderful information from not me, because I'm not the expert, but Shilpa is. So Shilpa, today, for everybody's delight, we're going to bust some myths, aren't we? So the first one that I would like to do after you've given a little bit of an introduction to yourself is we're going to talk a bit about blood tests. But Shilpa, why don't you tell everybody who's watching what you want them to know about you, because you're fabulous, but the clock's ticking. So you tell them what you want them to know about you.
I'll do it like a GP introduction, should I? So, yeah, hi, my name is Dr. Shilpa McQuillan. So thank you very much for the introduction. So as Amantha said, I'm a community gynaecologist. I'm also a women's health GP, and I founded and run my own menopause and women's health clinic called Berkshire Menopause Clinic.
Which is amazing, isn't it? It's amazing that you've done that. So how lucky are the people of Berkshire and the surrounding area? But you're so much more than that as well, though, aren't you? Because you take your information and you're renowned for writing articles, speaking. If you're interested in getting Dr. McQuillan in, get in quick because she's popular. But what is your website that people can take a look at you on?
So it's Berkshire Menopause Clinic. So it's www.berkshiremenopauseClinic.com. I'm on LinkedIn as Dr. Shilpa McQuillan, and on social media as Berkshire Menopause Clinic as well. And as you said, Amantha, I do lots of education. So I write for the Henley Standard, which is a big newspaper in South Oxfordshire. And they've also now asked me to be the women's health columnist for them for their Henley Life magazine, which is a life and wellness magazine. So if you want to sign up or look at any blogs, then go onto my website and it's all for free. You can sign up and get some education from me.
Yeah, absolutely. So this is brilliant. So let's get into, and we'll put all your details on each episode so that people can be in touch with you, and we'll put this out on LinkedIn and Instagram. So, okay, imagine I'm a patient and I come in and I'm all a bit of a flap and I go, okay, doctor, so we had this thing at work and I'm just wondering, should I be getting some tests, blood tests, to actually diagnose whether I'm in perimenopause or menopause? What do you think, Dr. Shilpa?
Absolutely. So the important thing you said at the beginning was allowing patients to have that time, because it's not as simple as that. So taking a really thorough history, where are you in your menopause journey? We've discussed this before. Perimenopause starts 8 to 10 years before, and therefore you might still be having periods, and often people are. Why is that important for blood tests? Is that when we are perimenopausal, or even sometime after being menopausal, our blood tests are very erratic. They fluctuate not only day to day, but by hour to hour. And so, especially when you're having periods still, those blood tests are going to be normal. And so what I say to patients is, how's it going to change the way we help you and the way we manage you? So if I did a blood test on you and it was normal, does that mean I should deprive you of helping you for treatments? Because as I've just said, perimenopause, 8 to 10 years, some people really suffer with symptoms. But with completely normal blood tests, those symptoms could really be helped and their quality of life made better with treatments.
Absolutely. And I love that answer because that was me. I got my first symptoms when I was 36 with a 2-year-old, and I'm pretty sure this is going to be my final year of being perimenopausal at 52. So, that's a long old time to, have to be ticking boxes when I could have been benefiting. And so it's really powerful, isn't it? So symptom checkers. Now, I know someone who's got a great symptom checker on her website, and Shilpa has, great resources available. So she's got a Mythbuster worksheet there, but she's actually also got a symptom tracker of her own that you could literally download, start completing, so that you can go to that 20-minute appointment more armed with information. I mean, that's a good thing, isn't it, Shilpa?
Absolutely, because as I said, leading up to menopause, your periods could be erratic. You might not be having periods. They might be quite sparse. But what it can do is help identify, are you getting symptoms at certain times of the month, even if you're not getting periods? A lot of women get that fluctuating hormone PMS-like symptoms. So at certain times of the month, they may get headaches, they may get mood issues. And so it really helps identify whether this could be hormonal, when in the cycle it could be happening. And also, don't forget that we have so many women who are given things like antidepressants for mood disorders, for things like headaches, when actually it could be hormonal and helped with hormonal treatments. So given that symptom diary helps you both identify together, could there be a pattern to this? Could there be something more to it and more hormonal?
Yeah, I love that. And I love the collaborative style, by the way. I think I love it when someone wants to work with me on something rather than just do things to me. So what about then, so let's say I trot in again, patient number 2, and I say, oh, Dr. Shilpa, brilliant that you're doing these great myth busting sessions. I've got a question about, can you put me on HRT? Because then that will delay the menopause. That is going to delay the inevitable, isn't it? If you stick me on HRT?
So really good question. So HRT does not delay your menopause. So this is a very common question I get asked. If I go on HRT, and sometimes you've said it in a positive way, some people worry that it's going to delay it. So that actually what's happened is it means they're just going to end up with menopause for longer. So it doesn't do that. What we're doing with hormone replacement therapy, HRT, is we're topping up your hormones that are already going down. So by topping you up, we're not masking anything. So the way I describe it is everyone's individual. Some people sail through menopause, don't have any symptoms. Some people have symptoms for years. If you go on HRT and then a time you come off it, you don't have symptoms anymore, the chances are your symptoms would have been finite for that period of time, with or without HRT. If you were to try and come off HRT and you still had symptoms, that's not delaying your menopause. It means that for that period of time, you will still continue to have had symptoms. So what that HRT is doing is just helping you manage those symptoms. So it doesn't delay anything. It's just treating those symptoms and improving your quality of life.
Brilliant. I love that explanation. I was doing this with my hands earlier today, talking to a client saying, this is what your baseline hormones will always do, because you'll always have access to some of your own hormones. But then you come in with HRT, you've still got those little ripples underneath, haven't you? So it is so important, that question, that, nature has already got a bigger plan in store for us. What we're offering is that ability to just manage that process a little bit better, isn't it?
I'm just going to expand on that a little bit, because a lot of women, like, quite concerningly, feel that they're failing by taking HRT. They feel like, I should be able to just get on with this. But it sounds cheesy, but what I often say to patients, if you were diabetic, would you just not take insulin? If you had a thyroid problem, would you just not take thyroid? No. And the same with hormones. If you've got hormone deficiency, remembering I said everyone's individual, the symptoms range so dramatically between people, but some people really have debilitating symptoms. And by taking those hormones can absolutely improve quality of life and make such a difference. So I always put it like that. You've got a deficiency in something, or you're lacking something. We're topping it up to try and improve your symptoms. We're not trying to mask anything. And nobody's failing. If anything, I always say to patients, the fact you've admitted something is wrong and you want to get help, that is the best courage, I think, personally, in somebody.
Definitely. And we owe it to ourselves to be looking after ourselves. It's the ultimate self-care, isn't it? So let's imagine, okay, so patient number 3 is outside, so I better go. Okay, patient number 3 is coming in, and patient number 3 says, yeah, it's all very well. I mean, I'm 52, Dr. Shilpa. I can only be on this till I'm 60, can't I? If I take this HRT stuff. then I've got to stop it, haven't I?
Again, really good question. So for me, it's number one is about safety. So I'm gonna explain what I mean by that. So just to answer your question in a quick answer, the answer is no. You do not have to stop HRT by 60. So both the British Menopause Society and NICE guidance have very clear guidance that there's no arbitrary limit about how long you go on for HRT. And I still have women on it at the age of 80 something. The important thing to remember is that we're safe. So what I will say to women is when they're on established HRT, we do those annual checks to check for your blood pressure, to check for cholesterol, to check for diabetes. Why are we doing this? You just had an absolutely brilliant talk with Vikram on World Menopause Day about cardiovascular risk. So the reason we do all that is our risk naturally of heart disease and stroke increases as we go through menopause. What we know about HRT, it doesn't cause heart disease or stroke, because that was the worry. That's why there was that worry, and that myth that we're busting is that I have to stop it because there's that risk of stroke. Yeah. So the newer HRTs, we don't have that risk. But what we don't have enough evidence about is that if you have unstable heart disease or unstable stroke, whether giving HRT can throw off a clot and then increase that risk. So in unstable heart disease, we don't have that evidence. What can taking extra hormones do? Which is why it's so important that someone on HRT still has those annual checks, regular checks, and our natural risk of stroke increases over the age of 60 as women. So we should be extra vigilant that we're making sure we're taking care of our blood pressure and our risk of heart disease and stroke. And if that's all okay, as I said to you, as long as I'm being a safe doctor, ladies can continue. The opportunity at 60 also arises that if someone's on a traditional HRT, like oral synthetic HRT, which does hold a slightly higher risk of stroke or clots, that we have that opportunity to talk to and discuss with the patient in a patient-centered manner. So talking with you about, look, our risk of stroke naturally increases. There's that slight higher risk with oral. Now might be the time to consider, and I would heavily encourage patients, in fact, to go onto the ones through the skin, the patch, the spray and the gel, because there's no increased risk of stroke or heart disease with those. So it's an opportunity to look at types of HRT, and also looking at our risk of heart, our longevity. That I use that word so much, Amanda, longevity, because it's, for me, it's not just about a quick fix. It's about giving women their best life long term, and that includes looking after our lifestyle and minimising our risk of stroke and heart disease. And that's what we're doing with these annual checks.
Absolutely. And now I know patient number 4 is waiting, but I just got one other supplementary question to ask, because you're so good, is when we say HRT, do you mean both estrogen and progesterone co-prescribed, or is it different if, like, for example, I don't have a womb and I'm only taking estrogen? Is it still the same answer to that question about over 60?
No. So you would still need to check. So there's lots of different types of progestogens.
Yes.
So you've got the body identical, the newest ones, the capsules that people take. So that we know there's no increased risk of stroke or clots with them. We also know it's the most breast friendly. So I've been talking about heart disease. Let's not forget about risk of breast cancer, which naturally increases as well. There are other forms of progestogens as well, though. There's synthetic progesterone, such as medroxyprogesterone. People might have heard of it as Provera.
Yes.
There's things like northisterone, and there's things like a Mirena coil, for example. Now, we all know there's synthetic types of progestogen. So progesterone is your natural progesterone in your body. Progestogens are a synthetic derivative. So they hold slightly higher risk of stroke and clots, but also some of them hold a higher risk of breast cancer. So what we're doing each time we see you as a doctor, we're assessing those risks. And we're assessing which type of progestogen are you on, which ones might be safer. And again, I throw this at you every time. It's about individualized care. It's about taking a really good, thorough history from someone and seeing what are their individual risks. Could they have a higher risk, and tailoring treatment according to risk and also symptoms and their desires as well.
Excellent. Well, that's lovely. Well, I know patient number 4 is waiting, so I'll move out the way and let her come in. Okay, Dr. Shilpa, I was just wondering, so it's great, gain on HRT. Thank goodness I don't need to have contraception at the same time, because HRT is contraception, isn't it?
So very, very good question. You wouldn't believe how many patients do not think they need contraception. And there's two most common scenarios here. people that go on HRT who think they don't need contraception because they're taking both estrogen and progesterone. So let me just explain that. So HRT, so what we're doing is estrogen helps our symptoms. Progestogens are protecting our womb lining from cancer. Because if we gave estrogen alone, it would thicken our womb lining. That's why we give progesterone for anyone with a womb. Now, the progestogen that is in contraception, we know we don't have enough papers, enough evidence to say that is enough to protect our womb lining over time from getting thickened and at risk of womb cancer. That's one way.
Okay.
The other way is therefore we need a different type of progestogen for HRT. So conversely, we also don't know that the amount of progestogen in HRT is enough to not get pregnant. No, sounds a bit weird. How can one be higher? How can one not be higher? How do we know? The answer to that is there's just not been enough research on it. So we cannot confidently say to someone, take HRT, you won't get pregnant. So what I would say, the only progestogen in a HRT is a hormone releasing coil. So a Marinacol, Levocert, Benelixir. They're the three that are licensed to be used as part of HRT, but also are enough for contraception. Whereas all your other forms of progestogen as part of HRT, your pills, are not the same as a contraceptive pill. So the answer to that is no. So the amount in contraception isn't enough to protect our womb line in HRT, and vice versa. The amount in HRT, we don't have adequate data to say, yes, you won't get pregnant on that.
Yeah, see, I told everyone you were good, didn't I? So he's explaining something complex in a simple way, which is brilliant. And so, right, so that other patient's coming in. So one other quick question then about that, because I get this question a lot from people, which is, I still don't feel I'm getting the benefit. I've got a Marinacol and I'm on a low dose of estrogen through the skin. I don't feel I'm getting the benefits of the progesterone. And one of the things I commonly have to explain to people is about the localized effect of things like progesterone in the womb. So from the Marinacol, what can you say to people about, are there cases where people would actually need more progesterone systemically? And can they have that as well?
Okay, good question. So it depends. People, I would say, often think HRT for their symptom relief, they use progestogens. Now, I'm going to start by saying there's actually lots of research going on, because in America, they do give progestogens alone, because we know progestogens act on precursors to pregabalin, which sedate people. And so we know that when we give progestogen, it can help with things like sleep, which is a very common symptom around menopause. In this country, we don't give progestogens alone. I should wear a T-shirt. We need more research. That seems to be the common theme, doesn't it? In everything. Yes. Let's be honest. But we've had such a drive. We've got such amazing research going on now. So things are getting better. But I like to say I want to wear a T-shirt saying that, because we don't give progestogen alone. But we know from other countries, people do get these benefits. So when people say that, that's why I've, in a long-winded way, answering your question, is that I get asked that a lot. And people don't actually know what are their symptoms caused by estrogen deficiency and what are progestogen. And they often think it's a progestogen deficiency, or an overload in progestogen, when it might not be, because the two present very similarly. So both estrogen and progesterone can give you bloating. They can give you breast tenderness. They can give you mood issues. And so you need to really take a good history from that patient and find out what are your symptoms, because actually it may be estrogen deficiency that's causing that. Where patients may need more progestogen is actually when you see people being put on estrogen doses that are very high above licensed doses. Yeah. And that's where it gets murky water. So even as a menopause specialist, I am still very careful. I don't just willy-nilly shove people on lots of estrogen and then just add in a bit more progestogen. Two reasons. We don't achieve research. We don't have enough data. What is the right dose of progestogen that will protect people's womb line above licensed doses? Because all our data till now is up until 4 pumps of estrogel, 3 sprays of Lenzetto, 100 microgram patch. So we don't know above that. Yeah. We're doing guesswork by adding in some extra. But the other problem people have, Amantha, with giving all this extra progesterone or giving all these extra hormones that they might not need, is something called tachyphylaxis. And that is where if you give someone more hormones than they actually need to control their symptoms, I'm going to explain it in a way. I throw water at you, you'll blink, won't you? Eventually, you're going to stop blinking because you're so used to me doing that. And that's what happens when you give high doses of treatment that aren't necessary, is that you're used to it. Your blood levels go up, but your symptoms then come back. And it's very difficult to reverse that. So what I was saying in answer to your question is that it's so important to really hone in what are your symptoms, and let's really find out, actually, is it what you think it is? Is it really progesterone that you're needing? Is it really, or is it an estrogen deficiency? And if so, let's do it step by step in a tailored way so that we get it right and we're not doing unnecessary, unsafe things.
Absolutely. And as an informed patient, I would say, please don't tinker around with your doses yourself. All those should be directed by your medical provider, like someone like Dr. Shilpa, or a medical professional, not what you're seeing on social media, not what you're reading in posts here, there, and everywhere. This is really highly potent stuff, and it's important that we don't tinker. We're not specialists ourselves, so trust the professionals.
Well, just from a sympathy point of view, people are sitting there waiting to have their GP appointment. They're waiting to see a specialist for months. And it can naturally, you feel like, well, in that meantime, why don't I just increase my dose because I'm really suffering? So I completely sympathise, and I'm never flippant about the fact that, don't do it in a telling off way, because I do sympathise, but there are risks of doing that, and which is why I encourage people, please, if you can, wait to speak to your doctor, because I know it's easier said than done when you're really suffering and you've got the pump sitting there. It's very easy to just up that dose, but there can be consequences. And I get a lot of patients coming to me saying, I've only been on it for 2 weeks and I've upped the dose. Well, it takes 3 months for that dose to kick in. What we're doing is you're not going to get there any faster, and you end up going to be, resistant or not getting the right treatment. So I do sympathise, but please, if you can, just wait to speak to a professional.
Exactly. Speaking of waiting to speak to a professional, the next lady is waiting to come in, but she wants to speak to you. So let's talk about then vaginal estrogen. Now, this is something that was the bane of my life for quite some time. It is very common that women can often get urinary tract infections. They can get change in pH in their vagina, vulval area, all of those sorts of things. Won't just the topical estrogen sort me out? Do I need to have, I don't need the pessaries and stuff, do I? Do I need to have that vaginal estrogen? And can I stop that once I'm better? A bit like Canesten, I take that until the infection clears. Like, can I just stop the vaginal estrogen?
So this is really, really important. So firstly, some people, systemic HRT, so HRT that you're taking through the skin or through the mouth, often can resolve some people's vaginal symptoms. But what I say to women, this is again, comes down to asking those questions, because not everyone wants to volunteer their intimate, I have to pull it out of some people. They might not say I've got vaginal dryness or pain during sex. So I have to ask them. It's my duty to do that. So if I ask them that, I will say, even if HRT does resolve some of your symptoms, let's get on top of it. Because the aim of treatment is we want to resolve your symptoms, but we want to also stop it from getting worse. And that's going to answer your question, where I say to women, you can stay on it for as long as needed. And often women's symptoms will come back if they stop it. So the aim isn't just that quick fix. And also, I'm going to introduce here, don't forget about moisturizers. You wouldn't let your face get cracked. Let's not let our vaginas do the same. So it's just as important. I prescribe moisturizers as much as I prescribe vaginal estrogens and vulval estrogens. We call it vagina because they're a topical that you rub on not only your vulva, around the opening to the bladder because of things like urine infections, and as much into the vagina. And there are pessaries. Now, I want to go into this in real detail, and hopefully this will lead on to what we're going to talk about for our next one, because it's a lot more to it and I have a lot more to say. But to answer your question, there's both creams and there's pessaries. Some people need one or the other. Some people need both. People can stay on it forever. And even people with previous history of breast cancer. You heard Dr. Alison Macbeth, incredible doctor, a breast cancer specialist. We do give it to people who've had breast cancer. These poor ladies have extreme vaginal genitourinary atrophy. So it's a myth to say they can't have it, but it's again about being safe and taking a history of what medications what chemotherapy or hormone therapy you might be on for that cancer. But the answer is most women can take vaginal estrogen, and I tell them not to stop it for lifelong.
Exactly. Now, look at that, Dr. Shilpa. I know we've done a little bit of a sketch here, but first of all, thank you so much for literally getting through all those questions. But I hope that it really does demonstrate to people, by booking a double appointment, by thinking about a little bit about what you want to ask, by writing it down, you stand the best chance of boosting your own confidence, boosting your empowerment, your levels of empowerment, advocating for yourself. Take someone with you if you need to. But I know we've sort of done that in a jokey style fashion, but that is really the benefit, isn't it, to why you and I are doing this series, because we want to encourage people that there are no questions off the table here. We'll you know, we want to ask those difficult questions, and that's why our second topic that we're going to talk about is intimacy. We're going to talk about what that's like. So can you sort of tease up, as you do with intimacy, can we tease up some topics, some sort of statements for people about what they can hope to get from that next video that we do?
Yeah, absolutely. So the first thing I just want to carry on from what we were just talking about is about things like what kind of treatments can you use, who can use them, when can you use them. You know, there's lots of difference. You know, is it to do with sex? Is it to do with everyday treatments? So I want to cover all of that in terms of who should have treatment, why should you have treatment, when should you have treatments, and what are the types of treatments we can have. Then I really want to cover about libido, because I think one of the mythbusters I get as well is about testosterone and libido. And I really wanted to discuss that as well, because I think it's such an important topic that people don't feel like they can volunteer. But also there's been lots of media coverage, hasn't there, about testosterone and intimacy and low libido. And I really want to delve into that, Amantha, and just discuss it, because it's not as simple as that. And again, individualized care, it really takes listening to that person of what's going on in their life to try and work out why are they having intimate or libido issues. And then with that, I will address when testosterone is appropriate as well.
Yeah, because it is really important, because menopause can be a lonely time. And actually, if you lose intimacy, and that's not just with your partner, that's actually with yourself. If you lose that intimacy with yourself, and as I spoke to a sexologist before, and they talked about pleasure, if you lose that capacity to find pleasure for yourself, yeah, it makes things even more difficult, I think. And so it's a really important topic. So, well, we've covered loads of myths there, and there are so many more. But what we want people to understand is formulating your question, formulating what you want to ask a doctor. It doesn't need to be difficult. Get yourself a notebook, write down what your thoughts are, get the symptom tracker like we've demonstrated from Shilpa's website. Follow Shilpa. I mean, my goodness, why wouldn't you? And we will do more of these. So we have another 5 episodes coming up, but we've deliberately done them short and sweet so that actually you can do something with them. So what do we hope people will do as a result of this video, Shilpa? What's your hope that people will do as a call to action as a result of watching this?
Well, I hope the myth busting has really helped people from an educational point of view from listening to this, but I hope it will empower them. Right, I'm going to do a symptom diary. If I need help, I'm going to take that. I know that actually to get where I want to might require more time. So I'm going to book a double or a follow-up appointment. You know, it's not that easy in a GP surgery. We have to take the practicalities.
Of course. Or
they can seek a medical menopause expert. And if you went on the British Menopause Society, it's not just private. Obviously, I appreciate, you know, I do private work, but also an NHS-based menopause specialist. On the BMS, we'll show you accredited menopause specialist if you type in your postcode. And so your doctor should be able to refer you to a menopause specialist. So this will empower you to just write all your questions so you get maximum out of that appointment for you.
Well said, and a great reference point too. So we will put some of those links. We'll put the British Menopause Society, we'll put your website address, and like I say, go follow Shilpa because she's absolutely brilliant. So for now, Shilpa, I think there's more patients waiting for you, so we're going to need to stop. So thank you so much for your time at what is at the end of a very busy day for you, I know, but we're all hugely grateful. So until next time.
See you then, everybody.